Hello. I'd like to thank the British Journal of Urology for inviting myself and my other co-authors to contribute to this week's Article of the Week. In our article, we update the guideline of guidelines for non-muscle invasive bladder cancer. In our update, we review guidelines for non-muscle invasive disease from 4 major organizations. All guidelines agree that a thorough and complete initial transurethral resection of all visible lesions is crucial to establishing a starting point and risk assessment. Guidelines include detrusor sampling, and recently the EAU included en bloc resection if possible. A recent meta-analysis by Chu and colleagues found lower rates of recurrence and long-term progression using blue light cystoscopy at the time of TUR compared to white light cystoscopy, encouraging the EAU to use enhanced cystoscopy when possible. Similarly, blue light cystoscopy is recommended in the surveillance setting, after a recent randomized controlled trial found 20% of recurrences were only detected using blue light compared to white light. In addition to TUR, the mainstay of treatment for non-muscle invasive bladder cancer includes single-dose postoperative chemotherapy for low-risk patients and induction plus or minus maintenance BCG or chemotherapy for intermediate and high-risk patients. A recent trial showed no differences in the rates of progression for 1 year of maintenance BCG compared to 3 years of maintenance BCG, although longer maintenance schedules did contribute to lower rates of recurrence. Recent EAU guidelines also include clearer definitions regarding patients who do not respond to BCG in order to further identify patients who may be appropriate for clinical trials or early radical cystectomy. Finally, the AUA, endorsed by many other societies and the NCCN, created recommendations for management of non-muscle invasive bladder cancer in an era of low BCG supply. Adjusted dosing schedules, preserving BCG for naive patients, and consideration of alternate intravesical therapies or trials are included in these guidelines. There are many clinical trials that are currently available and should be considered, particularly for high-risk patients who do not respond to BCG when BCG is not available, or for patients who are simply not radical cystectomy candidates. We hope you will read our paper and find it helpful in the management of non-muscle invasive bladder cancer patients. Thank you.